Okay, so hello and welcome everyone to tonight's webinar, the third in a series of 5 sleep webinars brought to you by Capital Health Network and a multidisciplinary team of sleep physicians and allied health professionals in the ACT. Firstly, I would like to acknowledge the traditional custodians of the land that we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders past, present, and emerging. I also acknowledge and welcome any Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. Tonight's webinar focuses on obstructive sleep apnea and comorbid insomnia and sleep apnea. I'm Michaela DeLeva, a physiotherapist and quality improvement project officer at Capital Health Network. Also with me tonight are respiratory and sleep medicine physicians Dr. Daniel Wang and Dr. Samuel Wells. And of course, we have Kanal Mohiti, the events lead at Capital Health Network. I'll just start with a little bit of housekeeping. So all participants have been muted. Please address any questions that you might have in the Q&A section and not in the chat box of the side panel of your Zoom window. And we will have a question and answer session after both presenters have finished. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding continuing professional development, please fill in the post-event evaluation survey. CHN will email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. Before we start, I would like to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including insomnia, obstructive sleep apnea, and other sleep disorders. If you're interested in having a look at our at the Health Pathways website, the login is together and the password is for health. Health Pathways are a reliable source of up-to-date clinical and referral information that is localized to the current area. Your feedback is invaluable to keep the pathways updated and reflective of the local health environment, and you'll find a feedback tab at the bottom of each pathway. I would now like to introduce our speakers for this evening. So our first speaker tonight is Dr. Samuel Wells. Sam is a respiratory and sleep medicine physician who has returned after recently completing his training interstate at Wagga Wagga Base Hospital and Westmead Hospital. He graduated from the ANU Medical School in 2014 and completed his early training here in Canberra. He is now completing his sleep fellowship at the Canberra Hospital, in addition to working as a staff specialist in respiratory medicine. He has a broad range of interests, which include research interests in obesity and its impacts on sleep. Sam grew up in Canberra, where he is living now with his wife and 2 children, and is excited to grow his career here. Please join me in welcoming Sam.
Thanks very much for the kind introduction. I'll just see if I can share my slides with everyone. Okay, so hopefully everyone can see my slides there. So the topic I'm going to be covering today is obstructive sleep apnea. As you would all be aware, this is a big topic for a big problem. Because there's so much to cover, I thought we'd just get straight into trying to cover it all. So we'll do an introduction, go through some definitions, have a quick chat about the pathophysiology, epidemiology, risk factors, and then have a chat a bit more about clinical presentation, approaches to diagnosis, try and take an overview of all the different management options that we have available, and make sure we have time at the end to have a chat about the driving considerations, particularly important for our commercial drivers. So obstructive sleep apnea, really common disorder that we all see many days. characterized by repetitive pharyngeal closures during sleep, closures which are either a complete obstruction causing apnea or a partial closure causing hypopnea, so reduced airflow but not completely absent. These interruptions in airflow will lead to hypoxia, hypercapnia. There's autonomic fluctuations with increased sympathetic drive, dysregulation as a result, and then ultimately arousal from sleep. And it's these arousals from sleep that result in fragmented and unrefreshing sleep that then presents often with daytime sleepiness. These disturbances also increase our risk of cardiovascular disease, cerebrovascular disease, diabetes. There's increased risk of motor vehicle accidents when there's excessive daytime sleepiness, and there's a reduced overall survival as well. And as we're all abundantly aware, its prevalence is only going to keep increasing as we have increasing rates of obesity. So just a few definitions, and really just for reference, what we look for on the sleep studies, our apneas are any event where there's a greater than 90% reduction in airflow for at least 10 seconds. Our hypopneas are a greater than or equal to 30% reduction for at least 10 seconds, but they have to be significant, so they have to be associated with desaturations of at least 3%. Our RERA is where we see a respiratory effort that doesn't meet any of those criteria but still leads to an arousal. The arousal, by our definitions, are an abrupt upshift in EEG frequency to a lighter form of sleep or to a brief awake period, more a brief awake period that will often then revert back down to the stage of sleep that the patient was in. Our AHI is one that I'm sure everyone's familiar with. That's our apneas plus our hypopneas per hour measured for the duration of sleep. Our RDIs are those plus the RERAs, and less frequently referred to these days, can be important if there's frequent amounts of RERAs that we think are disturbing sleep that then may not be reflected in the AHI. Now, the REI is one that's going to come up more later in the talk, and this is actually our recorded events index. So that's the apneas and hypopneas per hour of recording time on our sleep study devices that we use in the community that only record recording time and don't actually measure sleep, and that becomes important later. And then just a really quick reminder, our severity cutoff, so anything greater than 5 AHI is sleep apnea, and 5 to 15 is mild, 15 to 30 is moderate, greater than 30 is severe. So the pathophysiology, so it's not simply a mechanical problem, although that's certainly a significant contributor. There will be several key factors that play a role in the pathophysiology. So, of course, there is the upper airway anatomy as well as muscle activity. As we know, as we fall asleep and in deeper forms of sleep, this muscle activity is reduced and more relaxed, and there's collapse. There's also this idea of ventilatory control stability, which we'll talk about, and then the idea of the arousal threshold contributes as well. So, in terms of the upper airway anatomy, if you have a narrow upper airway, you're more likely to have obstructive sleep apnea, and this can be due to a craniofacial structure, either abnormalities or due to ethnicity. There might be increased soft tissue, often related to adiposity, increased BMI and obesity. There can actually be reduced lung volume. This is the one that's not often thought of, but when the lungs are fully expanded and increased, there's increased traction on the trachea and the upper airway, which helps to splint it open when the lung volumes are reduced in many mechanical diseases, but also, as you'd be aware, in obesity as well, when we often have reduced FRC. This can be another way that it contributes to upper airway collapse. Now, increased airway compliance, if there's increased floppiness of the airways, if we have increased airway mucosal edema, and that might be due to things like renal or cardiac disease as well. And there's obviously a clear interplay there. And then we have our reduced airway muscle activity with sleep, and everyone's level of activity can vary, but this is going to be a contributor as well, and how they respond to the negative pressure through the reflex neural pathways as well, as this is usually suppressed during sleep, and someone who's less responsive to this will likely be collapsed for longer. There's then this idea of ventilatory control. You might have heard of this concept of loop gain, this idea of the response to the disturbance over the disturbance. So when you have a low loop gain, the response is measured. So if someone's carbon dioxide goes up to represent that they've slowed down breathing, there's a response that simply corrects it without overcorrecting. If they have a high loop gain, if they have an overreaction to these changes, they can actually drop the carbon dioxide again to a level where it's no longer going to be where it's below the apneic threshold. So the body stops breathing again, the carbon dioxide goes up, you have the same overreaction, and this cycle can actually perpetuate these obstructive events. And then this idea of arousal threshold. So the threshold at which the respiratory effort, represented by hypoxia, hypercapnia, increasing negative airway pressures from effort, result in the arousal of the person, to then result in the compensatory hyperventilation and restoration of upper airway muscle tone. And unfortunately, at both extremes, there's negative implications for OSA, because someone who has a high arousal threshold is going to stay asleep for longer during their apneic episodes and are going to become more hypoxemic overnight. Whereas patients with a really low arousal threshold are going to hyperventilate more frequently, maybe increase their loop gain. They're going to have more fragmented sleep and maybe more disturbances there as well. So a little bit on the epidemiology. So it's quite a common condition, and the estimated prevalences in America are 15 to 30% in men and 10 to 15% in women, sort of across descriptive epidemiological studies. And thought that maybe 10% of men and 5% of women will have OSA that's associated with excessive daytime sleepiness. So an important marker that it's not always going to be symptomatic, but in someone who has comorbidities that can be affected or exacerbated by OSA, we need to think about patients at risk even if they're not presenting with symptoms. And then this one I think is interesting. So there was actually a cohort in Switzerland of 2,121 people where they actually signed them up to have sleep studies in a general population cohort. And they actually found in this group where they actually got to study everyone, 50% of men and 23% of women had moderate to severe OSA. So that really sort of highlights this possibility that we might actually be missing this or underestimating how prevalent this condition is. So the main risk factors, and I'm sure that you're all quite across these. So men, it's 2 to 3 times more likely than compared to premenopausal women, maybe due to central fat deposition around the upper airway. There might be, and maybe around the chest, reducing the lung volumes as well. They have this longer upper airway, and that's independent of height and BMI, which is potentially more prone to collapse. Again, our patients with obesity, we've covered that a bit already. Our older patients, there's reduced tethering of the upper airway, making it more prone to collapse. There's loss of elasticity leading to lung volume reductions, loss of collagen, reduced arousal thresholds. All these things can contribute. Postmenopausal is something that's been seen in epidemiologic studies. The exact reason why I couldn't find a clear answer for it. It's thought to, at least in some part, be related to hormones. So as there were patients on HRT that was found to be protective against the risk of obstructive sleep apnea. The craniofacial stuff we've mentioned as well. It's simple. That is a simple structural issue, but particularly in patients with Asian ethnicity, we do have the studies that show that they have a craniofacial structure that's more likely to result in OSA. And this is why the prevalence rates in these countries can often be similar to what we see in Western countries, despite having lower average BMIs. Smoking, not really known exactly why this is a risk factor, maybe due to airways inflammation or upper airways inflammation, sinus issues, probably reduces the arousal threshold as well, being a little bit stimulant as well. And we know there's family history associations as well, which seem to imply at least some sort of genetic basis, but sure that there's going to be contributions from the environment and learned behaviors as well. So in terms of complications, excessive daytime sleepiness is the one that we know. This is the one which can be clearly improved with CPAP when it's effective, and it's resulting in an increased risk of motor vehicle accidents, so up to 7 times more likely in untreated OSA with severe excessive daytime sleepiness. Systemic hypertension is something that does have a clear causal link. It's been shown in animal models and epidemiological studies, and has been shown to improve to varying degrees with CPAP therapy, including evidence from meta-analysis. Type 2 diabetes, so it's an independent risk factor for diabetes, independent of BMI and obesity and those other risk factors, with some evidence that the worsened glycemic control might be related to the loss of slow wave and REM sleep in terms of the architecture. And there's even some RCT evidence, it's not across all of them, but there are some RCTs that have shown CPAP can help improve glycemic control as well. So there's a number of cardiovascular, cerebrovascular complications that are important. OSA is an independent risk factor for atrial fibrillation, and we often see this quite commonly. They have a lot of shared risk factors. From the reading I did, it's not been a 100% proven causal link, but we're all very suspicious. Probably linked to a number of things. You have these recurrent hypoxias. There's increased sympathetic tone. There's these vast alterations in intrathoracic pressure, which is putting strain on the atrium, maybe leading to fibrosis over chronic time and substrate to trigger atrial fibrillation. And while there's been no large RCT data, there are quite a few small studies that show that CPAP may actually help reduce the burden of AF. And I know this is something that continues to be looked into. Other arrhythmias, such as bradyarrhythmias, like sick sinus syndromes, are at a higher risk, and there's an increased risk of sudden cardiac death as well in patients who are greater than 60, AHI greater than 20, that have significant nocturnal desaturations. There's a significantly increased risk of sudden cardiac death. Heart failure, high prevalence in this group, lots of shared risk factors. Also a risk factor for central sleep apnea, which I think is going to be the topic of a future talk. And patients with heart failure as well as sleep apnea have increased symptoms, increased risks of hospitalization, increased risk of mortality. Coronary artery disease, also an independent risk factor as well. Cerebrovascular disease, meta-analysis looking at post-stroke groups have found 71% of patients will have an OSA, found to be independent risk factor for both incident stroke as well as recurrent stroke, and mortality and functional and cognitive outcomes in those patients as well. And pulmonary hypertension, another one I think we're quite aware of, but maybe in 70 or 80% of people with pulmonary hypertension confirmed on right heart catheter. And I think that's really important because even if there's another clear cause for the pulmonary hypertension, this obstructive sleep apnea may also be there compounding or contributing to it through nocturnal hypoxia causing pulmonary arterial vasoconstriction. And then a meta-analysis of 16 studies involving about 24,000 people have shown clearly that severe obstructive sleep apnea is associated with increased all mortality and cardiovascular mortality as well. And then just to be aware of many other associated conditions as well, obesity, hypoventilation, which we'll talk a little bit about down through the presentation, non-alcoholic fatty liver disease, end-stage kidney disease, lung disease, pregnancy, and obviously can cause complications in pregnancy, so low threshold for concern in patients with symptoms or risk factors, acromegaly, Parkinson's, polycystic ovaries. So in terms of the actual presentation, daytime sleepiness, this is the symptom that we all know about that's associated. And it might be described, even if the patient's getting normal or even extended sleep durations, they'll still say that they're waking up unrefreshed regardless. They might even complain more of insomnia, that they can't sleep, potentially due to sleep fragmentation, which we'll discuss a little bit, and needs to be sort of kept in mind because often trying to treat the insomnia with sedating medications can exacerbate the underlying sleep apnea. And Daniel has the joy of trying to explain how to convince a patient with insomnia that having a CPAP mask is going to be good for them and help them sleep. There are obviously some substances that we need to ask about that can impact sleep quality as well, such as alcohol, caffeine. If they're sleepy through the day, it can sometimes be important to differentiate sleepiness versus fatigue, and that's where our Epworth sleepiness scale can be useful. And if it's still a bit unclear, there's a fatigue severity scale that can be employed as well. And I'm sure that you're all familiar with the Epworth sleepiness scale here. A number of situations described with the patient rating the chance that they might fall asleep. And it's a nice way of both looking for it as well as quantifying it, because anything above 10 is considered abnormal, or 10 or above, and anything sort of above 16 or 16 or above is moderate to severe, and that's where our increased risk of traffic accidents really comes into play. So witness snoring and apneas, this can be difficult to assess if there's no bed partner to give the collateral history. Patient might wake with a dry mouth, which can be a clue if there's no one there to tell you that they're snoring. Also these days, I'm becoming increasingly aware that a lot of our smartwatches are now offering this actigraphy that can include recording snoring events. I think some of them are starting to try and measure continuous saturations to look for drops to alert people. This is going to be something that a lot of you as frontline practitioners are going to come across questions about patients' watches telling them they have sleep apnea. But I mean, it has the potential to offer useful information, particularly the recordings of snoring events. Snoring, quite sensitive for obstructive sleep apnea, 80 to 90%, but is not a very specific sign. Lots of us are snorers without actually having sleep apnea. Whereas if a witnessed apnea is actually there, that is quite specific for sleep apnea, which is self-explanatory. Now, the morning headaches, this is another important one to ask about. It'll be a bifrontal squeezing headache. It shouldn't have any nausea, photophobia. It might take a few hours to improve throughout the morning, but does generally improve. There's probably a lot of reasons why sleep apnea causes headaches, but the main one that we worry about is the possibility of hypercapnia, as it can be a clue to either the severity of the sleep apnea and even that there might be significant nocturnal hypoventilation, which may be due to other issues apart from the sleep apnea. Fragmented sleep as well. So many will wake up complaining of choking and gasping. Again, this is not a very sensitive sign, but is often quite specific for sleep apnea. They may wake with nocturia, and indeed we need to think about causes for nocturia, such as prostate disease, but it might actually be that apnea has woken them up and they just then feel like they should just go to the bathroom. Again, as mentioned, with all this waking, they might actually complain of sleep maintenance insomnia. And then important to just make sure we've ruled out other causes for why the sleep might be fragmented, like restless legs, pain, wheezing, cough, P&D. Maybe their partner is snoring. Maybe their partner has restless legs. Maybe their sleeping environment isn't ideal. And these other symptoms, consequences of the fragmented sleep, like poor memory, concentration, poor quality of life, and low mood, irritability, reduced libido, I think erectile dysfunction as well. And then we need to think about symptoms of potential complications. Are they having palpitations? Is there orthopnea or pedal edema? Are they having wheezing to suggest underlying airways disease? All sorts of other things that we've discussed already. And that sort of leads into the background, having a look at what medications they're on, what past medical history they have that might predispose them, not only to an increased risk of OSA or factors that might exacerbate, such as benzodiazepines or sedating antidepressants, antihistamines, etc., but also things that put them at risk of a more complicated sleep apnea or mixed sleep disordered breathing, like airways disease or severe obesity, increasing the risk of obesity or nocturnal hypoventilation that's separate from just the sleep apnea. These things that will come up a bit more later in the talk when we talk about actually investigating it, having a look at all the substances that might be impacting, both potentially giving an answer for their symptoms as well as impacting on the sleep apnea. And, social history, very important. Is there anything like shift work? Are they restricting sleep, and is this causing some of their symptoms? But more importantly, are they mission critical workers or commercial truck drivers, bus drivers, airplane pilots? These important jobs where catastrophe can potentially happen if there's a micro sleep at the wrong time. And things like family history, not just for sleep apnea, but for other sleep disorders, other comorbid risk factors can be useful as well. And then in terms of the clinical examination, so in terms of things more specific for sleep apnea, you'll want to assess the level of obesity, quantify it with the BMI, but they do find that assessing the central adiposity and waist circumference actually correlates more strongly with risk of OSA than just the BMI alone. You'll have a look in the mouth to see if they've got a crowded oropharynx. There's the terms Mallampati, modified Mallampati, Friedman score. I actually just made sure I confirm the nomenclature because it varies. And this is actually a modified Mallampati, modified from the original when they added the fourth class. And the Mallampati not actually shown here, despite the fact that it's labeled Mallampati. This is actually more the Friedman score, and it has to do with the tongue position. If the tongue is left in the mouth while you assess the oropharynx, then it's the Friedman position. If the tongue is stuck out, like down here, hopefully you guys can see my mouse cursor, then it's a Mallampati position. And, this largely both obviously assessed with risk of sleep apnea and severity, but the Friedman had quite a close link to risk of severe OSA and increasing Friedman scores. And you can see down here in this picture the difference. These are Mallampati 3, but you'd actually score him a Friedman 4. And then we just sort of all need to work to try and to get the terminology right. You might want to have a look in the sinuses and the nasal passages. Maybe there's a big nasal polyp obstructing things. Do they have retrognathia or micrognathia that's narrowing the airway? Do they have a large neck circumference, increase of 42 centimeters in men? And I think it's actually like 38 centimeters in women, and we average it to 40 when we do the stop bang. This is associated with a significant increased risk. You might also find a neck mass or something else that's increasing their risk. And then we're looking for signs of the complications. Do they have or associated conditions like acromegaly and hypothyroid associated? Maybe they have complications of AF, heart failure. Maybe there's signs of asterixis to suggest CO2 retention through the day. Now, I only put this up in the right corner to just show how long and unwieldy the list of differentials for daytime sleepiness are on UpToDate. Good to be aware if needed for a reference. But thinking about other sleep disorders like central sleep apneas or obesity hyperventilation syndrome as a cause, thinking about whether there's other things causing fragmentation like periodic limb movements, hypersomnolence, primary hypersomnolence causes like narcolepsy or idiopathic hypersomnia, circadian rhythm in sleep disorders, lots of different neurologic, endocrine, psychiatric, medication-related causes for daytime sleepiness. Fragmentation, similar, can be lots of different things. We already touched on a little bit in the clinical presentation. Choking gasping can sometimes be aspiration due to GORD or swallowing problems with increased risk overnight. They may wake with cough and wheeze with asthma. We mentioned the nocturia with the prostate. Maybe nocturnal seizures or parasomnias could be another reason to consider as well. And, the headaches, they might be that clue to an obesity hypoventilation or a nocturnal hypoventilation problem. If they're really significant and they're new and some of those risk factors are missing, then, maybe it's a space-occupying lesion. These are just other things to consider. So in terms of assessing it, the risk stratification, based on your clinical assessment, using scores like stop bang can be useful, but getting an idea of how likely you think sleep apnea is and, how much you think it might be uncomplicated versus complicated by some of the things we've discussed. And this becomes important for then planning the best investigations. And you might go through some of those causes, metabolic, etc., to look for exacerbators or contributors to daytime sleepiness or OSA. You may want to investigate for some suspected comorbid diseases if it's the first time that they're coming up as well, or vice versa. If they've got a lot of these comorbid diseases, even if the patient's asymptomatic, if they're at risk, you might start to think about assessing for sleep apnea. And then you simply just go and do a sleep study. But what does that actually mean? Because sleep study could be level 1, level 2, level 3. Is it a home sleep apnea test? Is it actigraphy? Where does PSG fit in? There's all this terminology that can sometimes be confusing and confounding, and actually knowing which test can be some of the nuance involved in what can often seem like a straightforward problem. So just I'll aware of time, we'll try and keep the recaps quick for those that aren't completely sort of across it. But the level 1 sleep study, it's your full polysomnography, it's the EEG, it's the SATs, it's the nasal flow monitoring, including both airflow as well as thermistor, like sensing the fine temperature changes with breathing. It's your abdominal and thoracic bands to measure effort. It's the heart rate. It includes continuous carbon dioxide monitoring as well. It looks at chin, eye, limb leads, leads to assess muscle activity to help distinguish REM. In level 1, you've got continuous video monitoring, and you have overnight monitoring by a qualified and experienced sleep scientist the whole time, who can adjust the monitoring when things go wrong, and they can also fulfill other functions which we won't go into, but like when we start to do treatments, they can help titrate those. The level 2s, particularly that we run, are essentially the same. They have all the same monitoring attached, and the person comes in, gets set up like a science experiment, and goes home. We can't do the carbon dioxide monitoring at home, though, which is important to know if you're thinking about hyperventilation overnight. And there's no video monitoring as well, but otherwise it's a very similar study. The level 3, these are the home-based sleep studies, and they're important to know, because that can be a broad range of differences. They essentially have no EEG or EMG to monitor or characterize sleep. They may use accelerometry to estimate sleep, but this often overestimates the amount of sleep that's there. They may or may not look at the limb activity. They will often use flow and bands on the chest or abdomen to assess effort. But there are some that actually use this peripheral arterial tonometry to gauge respiratory events, which, although validated, tends more often than not to underestimate things. And then you've got this actigraphy, which I just mentioned again because patients will start to come in with their smartwatches to tell about the snoring and potential sleep apnea, but it tends to overestimate things, particularly related to the amounts of sleep and deep sleep as well. And we don't really generally use it in a clinical diagnosis of OSA. We use it for other problems. So in terms of whether you're going to do a PSG or like send in for us to arrange that, or whether you're going to look at if they're appropriate for a home-based study. So for the home-based sleep apnea test, there are quite a few pros. It can be easier to arrange. It can be cost-effective, although maybe not always available because of some costs to the actual patient themselves. Quite available, can be done from the comfort of your own home. And look, this comfortable gentleman, he's got a single band, he's got a couple of leads, but not heaps of leads. He looks pretty comfortable at home. But there are quite a few cons because we can't distinguish sleep wake. They will often measure the event records. So if you have someone who actually did spend a lot of that time asleep because they have trouble with fragmentation, with maintenance insomnia as well, you will actually get an underestimate of the AHI because it will include the time that they were awake overnight in the amount of time for events. So bigger denominator, basically. As mentioned, some will use peripheral tonometry, which has its issues. Some may or may not assess limb leads. If you're not assessing the limbs, you might be missing other causes for the fragmented sleep in the form of PLMs. So what about the PSG? Lots of pros. It's the gold standard for assessing sleep staging, AHI, all the other sleep parameters. It can help us not just assess for OSA, but a range of different respiratory and non-respiratory sleep disorders. It can look at whether there's hyperventilation. Video and scientists there can assess for parasomnias, for seizure activity. They can intervene if there's a problem with the recording so it doesn't become a wasted test. A lot of it can still be done at home with just a few of those things missing. It can also be used to titrate treatments, but lots more wires, lots more intrusive. If you're coming to sleep at the hospital, it's a foreign environment. It's more expensive, just generally speaking, although one pro is through the public system, it may not actually cost the patient anything, but there's going to be much longer wait times. It's a bit harder to access, and often they need to get to see the specialist first. So which one to pick? Lots of problems with the HSAT, but I think here in the real world there is a role for it. If you have a patient who you think is high risk or moderate to high risk of having at least moderate or severe OSA and uncomplicated by some of these other problems, then I think that this is an appropriate test. If they might have mild OSA, there's a chance you'll miss it on a HSAT. If they have a whole lot of comorbidities where missing it is going to lead to potentially worse outcomes or worse care, then it's probably not the right test. If they have features to suggest those things that will only get picked up on PSG, it's probably not the right test. If they're a mission critical commercial driver type thing, it's probably not the right test. this is sort of the converse of that. If they have any of these problems we've been discussing, then we really should think about a PSG. And, if you think they might have hypoventilation, parasomnias or seizures or anything like that, then you're really thinking level 1, to actually have the video there to be testing the continuous carbon dioxide as well. Now, in terms of management, we'll just try and touch on all of these quickly so we can get to driving and not take up too much of Daniel's presenting time. The general guidelines recommend treatment for anyone who has an AHI greater than 15, regardless of symptoms, or if they have an AHI of greater than or equal to 5 with either excessive daytime sleepiness and neurocognitive impairment, or if they've got a lot of comorbidities as well. But the way that people actually approach this could vary. And then in terms of the therapies available, there's weight loss, behavioral modification, there's positioning devices, there's the CPAP therapy, there's mandibular advancement splints to try and open the upper airway up more. There are surgical managements which tend to come in if these other things start to fail or aren't tolerated. The pharmacotherapies I just mentioned quickly, they're essentially still experimental. There's no large RCT, there's no FDA or TGA approval. They're sort of last resort things that are considered at the subspecialty level. So weight loss, behavioral modification, this is something we can start, even before we're suspecting sleep apnea, trying to encourage patients to modify diet, incorporate exercise, aim for weight loss. Obviously a very challenging problem that you all face. If they have a BMI greater than 40, they might be eligible for referral to our local public obesity management service. And there's multiple RCTs that show weight loss can reduce severity through reducing AHI to varying degrees, correlating with the amount of weight loss. There's exercise alone might improve the OSA even in the absence of weight loss. In terms of other behavioral modification, if they're drinking a lot of alcohol before bed, that's not a good idea. If they're using sedating medications for sleep, if they're on other sedating medications which can potentially be altered, these are all things that could be considered. Obviously complicated in competing needs for the conditions that they're prescribed for, though. Generally speaking, like all of this is very important and contributes to the treatment, but if you have someone who has moderate to severe sleep apnea, all of this by itself is not going to be enough. And that goes for the positional therapies as well. Unless you have a patient who on their sleep study very clearly only has sleep apnea on their back, this will be an adjunct but not necessarily the only treatment. And then your options vary with budget, from the simple tennis ball sewed into the back of the pajama top to these belts that help keep on your side, to these neck based shock collars that give you a buzz if you're on your back. Now, positive pressure airway therapy, this is recommended first line. People's approaches can vary, but the American Academy of Sleep Medicine says this is first line for anyone who has 5 to 15 with symptoms or AHI greater than 15. People greater than 30 are the ones that really benefit. When compared to no therapy, improvements in AHI, blood pressure, reduced vehicle accidents, reduced sleepiness, improved quality of life, everything basically. When compared to other therapies, superior, generally speaking. No direct comparisons to the hypoglossal nerve stimulation or other surgical interventions, because these are usually the patients who haven't been able to tolerate CPAP, so you can't really randomize them back to it. I like this because it's probably out of the other options, apart from behavioral modification, the easiest ones to trial. Lots of places around Canberra will offer services that can titrate it on a rental machine, that can help try different masks, and you then get direct feedback of the efficacy with the machines giving the diagnostic data about how well you're controlling the AHI. Obviously, there are challenges with compliance. Some people just can't tolerate it no matter how hard you try. But when we try pretty hard and go through a nice supported titration, you can often get uptake of about 70% of patients who are offered it. The mandibular advancement splints, they do what it says on the box. They advance your mandible, open up the back of the airway. Your mild to moderate cases who are young, who are women, who have more positional sleep apnea, who have evidence of a narrow airway are more likely to benefit. If they have severe or high end of moderate disease, it's probably not going to resolve the issue completely, and you probably need to look at the efficacy of it with a polysomnography. The surgeries are if these other things haven't worked, and they need to have specific airway, and anatomy for it to be useful, and that's assessed by the specialist surgeon. This is the uvulopalato-pharyngeoplasty. I think they just scoop out most of the upper airway. Here you can see the big tonsils that could be taken out, and here's the hypoglossal nerve stimulator to basically poke out the tongue during sleep at periods where there's obstruction. Just rushing to the last slide. I'm getting to the end of my time. I know this is a big topic that a lot of you see. So approaching driving and sleep apnea. So this is essentially out of the Ausroads guidelines, and you can see the differences between private and commercial. A lot of the actual criteria you can see are pretty much the same. The major difference is that the treating primary care physician can do all of this for private licenses. So if you have a patient who has straightforward severe sleep apnea, no complications, and you've done an appropriately ordered home sleep apnea test and found it and arranged for treatment, if that's in an area that is within your practice, and they're compliant with it, you can sign them off. If they have a commercial driver's license, they'll need to come and see a sleep specialist as part of those guidelines. I think the important thing is it doesn't need to be a sleep physician to actually make the call about whether or not the person is unfit to drive. If they have really clear symptoms of sleep apnea and daytime sleepiness, if they self-report episodes of sleepiness while they're driving or drowsy, if they've had an accident because they were sleepy or had a micro sleep, if your opinion based on any of that or any other assessment is that they're at risk, then they need to let the RTA know your concerns, their insurance company, all that, for a conditional license for potential period of review or suspension while it gets treated. The commercial driving, it's all essentially the same. Really the cutoffs that I sort of use and the ones that they use when they talk about moderate to severe sleep apnea, where my cursor is up here, is this ESS of 16 or greater. That's the definition bit here. And in terms of down here, when you're actually assessing compliance, it's looking at greater than 4 hours per day of CPAP use, which is proven to be effective with reduced AHI, of course, for 70% or more days of usage. And although I couldn't find it clearly in the Ausroad guidelines on the look through, like in terms of how long that needs to be looked at, most people I've worked with and sort of my own practice has been looking for at least a month of solid compliance data to just really make sure that it's well treated and there's no issues with compliance. If they can't use that, if they don't want treatment, any of those issues, a bit harder. The only way that we can really clear them is by doing the maintenance of wakefulness test. We give them a hot chocolate, we put them in a nice comfortable room with the lights off through the day, and we tell them not to go to sleep. And if they go to sleep, and after a few sessions, if they go to sleep, then they fail that. If they can stay awake, then without treatment, they've got proof that they can stay awake and they can go back to having their license. A very hard test. I don't think really being done in Canberra at the moment, though. So there's complexity there. So thank you for too much of your time. In summary, it's a highly prevalent condition. This is just going to increase. It's often asymptomatic, but has lots of comorbidities, complex pathophysiology. We need to be careful which patients we select for home-based community studies versus, and make sure we're not missing the patients who should go for polysomnography. We need to be especially mindful of it and potentially its asymptomatic presentation in patients who have significant comorbidities or complications. And for those with these sorts of things, we need to think about actually doing a lab-based or a home-based PSG assessment with a specialist. Lots of treatments, but generally CPAP when it's tolerated is the best. And all of those issues with driving. And it's the responsibility of the patient to actually report their condition and to take responsibility for their license, but it's our responsibility for doing that accurate assessment, for giving them all of this information, and then for trying to help them sort the problem out as fast as possible. All right, so thanks very much for your time. I will hand over to Daniel, who's going to do the second part of the presentation.
Thank you, Sam, for a very informative presentation. I would now like to introduce our second speaker of the night, who is Dr. Daniel Wang. Daniel is a respiratory and sleep medicine physician. He holds a staff specialist appointment at the Canberra Hospital and is the current director of physician education. He also works at RSCM, a respiratory and sleep medicine practice in Phillip, where he also acts as its medical director. He has wide experience in the treatment of both respiratory and sleep disorders and has a research interest in the interaction between airways disease and sleep. So please join me in welcoming Daniel.
Sorry, just trying to find the right buttons. Hopefully you can see my slides. Go. All right. Well, firstly, thank you all for attending today, and thank you, Sam, for your very comprehensive talk. And it's good to be in the company of many of the frontline healthcare workers and I've met many of you in some capacity. Clearly, OSA is a significant problem as per Sam's talk, the prevalence could be as high as 20%, but maybe as high as 50%, according to the RCT. And insomnia is as high as 30% of the adult population. And there's a great trouble for us, in the frontline healthcare system or trying to meet this demand. And so we need to look at different strategies. We need to look at, hopefully we need to increase, patient and, healthcare workers' education. And we need to give, we need to think about ways that we can, maybe different models of care. So today we're going to talk about comorbid sleep apnea and insomnia. And I thought I'll start with a clinical vignette. And this is a true story. And this is a patient that I previously reviewed. He is a 41-year-old rideshare driver, has an external sleep study in 2019 showing severe OSA with a AHI 58.6. Tried for CPAP for a few weeks, but can't tolerate it. And then this came to attention of his local GP. Has referred him to clinic in September 2021, predominantly because there was concern regarding his ability to hold a commercial driver's license. And then we made an appointment and we reviewed the patient in October. And it's always very tricky when you have a patient like that in clinic because, there's this balance where you are trying to maintain a therapeutic relationship, but then the patient's predominant concern is actually that's I may be a barrier to him holding a commercial driver's license. He's the sole breadwinner of his family, and he lives with his wife and 2 young kids. As always, when they are commercial driver license with a threat of losing their license, and they come and see me, his ESS was 0 out of 24. He denies any previous motor vehicle accidents and denies any micro sleeps. He actually describes a 6-year history of sleep difficulties. He found his sleep patterns were severely disrupted when his second son was born. He sleeps in the same room as his wife and 2 children, both 6 and 8 years old. They all go to bed at 9:30, and he doesn't have problems falling asleep, but he often wake up at 2 a.m. and be unable to fall asleep after that. So there's a lot of frustration while he was in bed, with him staying asleep. He gets out of bed at 6 a.m. and then he starts his work as a rideshare driver at 6:30. He snores, but there's no witness apneic episodes. He has a background of hypertension, hypercholesterolemia. He's a bit overweight with a BMI of 29.6, lifelong non-smoker, and alcohol intake. So at the first visit, we talked about bright light therapy in the morning to try and help his difficulties with perhaps we help him even better initiate sleep at night and maintain that. We discussed melatonin, 2 milligrams at nighttime, and also a auto-titrating CPAP. And we've told him not to drive commercially until we adequately treat his sleep disorder. And we discussed, again, this is somewhat arbitrary about how you define compliance, but as Sam said, generally we accept at least a average adherence of at least 4 hours and 70% of the nights. So he's come back to clinic on October, and he's given us given his strong motivation to hold a commercial driver license. He's came back and provided us with this he's currently gone on to use CPAP and come out and provided us with this data. And you could see that on device download, when on a variable APAP pressure, we find that his 95th percentile pressure was 10 centimeters H2O. He had a small amount of leak, which is acceptable at 5.4 liters per minute. Residual AHI was good at 0.5 per hour, and average usage that he could, with support through our acclimatization program, he could use the average usage. He had an average usage of 5 hours and 30 minutes. And now his main frustration is that for him, while he is using APAP or CPAP, he feels that although he's using it a lot, his sleep quality is worse, and he's actually not able to fall asleep on it. And when we look through his sleep studies, actually, interestingly enough, even though he reports insomnia, his previous sleep study in 2019 actually showed 399 minutes of sleep. So we thought, given there's some discrepancy between his symptoms and his response to therapy, I think it would be good to just have a repeat diagnostic sleep study to see what we're dealing with so that we can better tailor his treatment. He's continued bright light therapy in the morning, melatonin, APAP, and we discuss a cognitive behavioral therapy for insomnia with a private psychologist or a student-led clinic at the University of Canberra. And so this is a repeat sleep study, and hopefully you could see my mouse, and you can see that, even though the patient felt like, on the night of the sleep study that he could not sleep after 2 a.m., you find that, wow, he actually slept quite well. Like, there's this areas of green, which is the N2 sleep, and yellow, which is N1 sleep, and blue, which is the slow wave sleep entry, and red is in REM. Red shows the REM sleep. And even despite his report that he actually could sleep relatively, although there was some sleep fragmentation, he slept relatively constantly. In fact, on the night of sleep study, we had 362 minutes of sleep, even though the patient only felt that he might have slept for 2 to 3 hours. You can see his different body positions here. And you can see this is when he's lying on his left, and this is when he's lying on his right. So he did not have much supine or sleeping on his back. And you can see that if you look at his oxygen tracing, you can see that he had a lot more frequent events of apneas and hypopneas, especially in REM sleep. And you can see that the oxygen disturbance became much greater as it goes up and down at the times of REM sleep. I think the lowest saturations he got was 76%. He was snoring quite frequently. And so, he came back to the clinic, and we explained to him that, that not just that does he have obstructive sleep apnea, which is a problem. He also has insomnia, and he has a paradoxical insomnia, is what we describe it. It's a sleep misperception. The patient obviously went to sleep, but didn't feel like he slept at all. Maybe that's because of his sleep quality, and hopefully we address some of that with treatment of his OSA. But there's this degree of learned frustration as it's begun to associate this 6 years of sleep difficulties in the bedroom with frustration, and this perception that even when he wakes up that he may not have slept at all, when in fact there is EEG evidence that he actually slept throughout the study. So we at this stage we cleared him given that he has met the medical standards to hold conditional license, and we changed him to fixed pressure to see whether maybe a fixed pressure rather than a variable pressure might be better suited for him. But we also concentrated a lot at this time about treatment of his insomnia, with being strategic about the timing of his melatonin and his bedtime. And if you look at his subsequent reviews with treatment of both his sleep apnea and insomnia, his CPAP usage continued to increase. And we discuss cognitive behavioral therapy for insomnia. As you know, it's an issue for us, especially in terms of access and cost. But definitely the gold standard for treatment of insomnia. So that brings us to a question: what exactly is this condition, comorbid sleep apnea and insomnia? Is it a real thing? I mean, is it just because you have OSA that is very common and insomnia that is very common and it just coexists? And on top of that, OSA and also insomnia might share some of the sleep symptoms that are quite similar. And also the question that we asked is there a bi-directional relationship between sleep apnea and insomnia? Does one make the other worse? And again, if you look at the studies, you'll find that insomnia and a lot of patients with insomnia have OSA, and a lot of patients with OSA report actually insomnia symptoms. They share some shared features, and there are some features that are unique to insomnia, unique to OSA. And I'm just going to go through this really quickly. But this, for patients who have both, it is we actually find that there's greater emotional and cognitive impairments, and there is some theory behind why that's the case, because sleep deprivation can lead to a reduction of your upper airway muscle tone, and can increase collapsibility, upper airway collapsibility, and that can worsen your OSA. Insomnia can reduce your arousal threshold, so if it's easy for you to wake, then therefore perhaps you need less disturbance in your airflow, and for you to awake from sleep, and you could have a hypopnea that way, and that's counted as part of your AHI. And also, OSA is associated with frequent post-apneic arousals and surges in sympathetic activity throughout the night. And so when you have awakening, you might have this perception that actually you have not slept when actually you did. And of particular concern to us, especially seeing a subset of patients who may have difficulty acclimatizing to CPAP, those patients often have insomnia. So if you look at the OSA patients with insomnia symptoms in class 1 and cluster 1 and cluster 4, they actually had decreased CPAP acceptance. And this is for the cluster analysis of patients with OSA with disturbed sleep. So the patients with OSA and disturbed sleep, i.e. more insomnia symptoms, CPAP actually does not significantly reduce their insomnia-related symptoms such as difficulty falling asleep or waking up early. And if one of the ways that perhaps we need to try to address this problem, and one of the ways is to treat both. The gold standard for insomnia, for treatment of insomnia, as cognitive behavioral therapy for insomnia, and it is the first-line therapy for OSA is for CPAP. So what this study, LSE 2018, showed that for patients who had both CBTI, cognitive behavioral therapy for insomnia, and CPAP, they actually showed greater improvement in sleep measures and greater CPAP usage. I won't go through this in detail, but you can see that the CBTI group had more CPAP usage at 3 months and 6 months. So how can we address? I'm just going to talk briefly about how we can some strategies that we can deal with for addressing insomnia and also for OSA. Sometimes and oftentimes it is CPAP and CBTI, but sometimes we got to personalize our approach to the patient, and there's wide heterogeneity in the insomnia that you see, and the wide heterogeneity also in the OSA that you see. So just talking about insomnia, although cognitive behavioral therapy for insomnia is the gold standard, access is limited. We need a holistic and personalized approach. And you got to consider when talking about insomnia, you got to consider the impacts of medications, alcohol, caffeine, consider impacts of comorbid medical and mental health conditions, and also think about some non-pharmacological and pharmacological approaches. This is the example of non-pharmacological approaches that I use quite often. The stimulus control instructions is something all my patients who has insomnia. This is because of the concept where what happens with insomnia, chronic insomnia, especially over the many years, is that patients have begun to associate the bedroom environment with frustration and sleeplessness. And oftentimes it's interesting, right? You ask some of those patients with insomnia, sometimes they might give you a story where, they're feeling sleepy and they are getting a bit tired, they're falling asleep on the couch. And then the minute they go to bed and suddenly they're wide awake and they're frustrated and they're very highly strung at that time, and then they can't fall asleep. And that's because of they're remembering many years of frustration with, and the brain has begun to associate the bedroom with frustration and sleeplessness. So stimulus control instructions are trying to break that cycle. So if we talk about going to bed only when sleepy, using the bed only for sleep and intimacy, if you're in bed, unable to go to sleep, get out of bed and return only when sleepy, typically within 20 minutes. Get up at the same time morning, regardless of how much sleep was obtained, and not to nap during the day. Right, so that's stimulus control instructions. For some very motivated patients, I talk about taking a sleep diary, and sometimes we might even do a sleep restriction therapy. The theory being that, there are patients who will sleep for 6 hours, and sometimes, but then I had a patient who, actually, in fact, I just had a review with her this morning, who had chronic insomnia, but she used to go to bed at 6 p.m. And she can't fall asleep till 12 midnight. So she spent 6 hours frustrated in bed for many years, and only fell asleep but she woke up at 6. So she basically spent 12 hours in bed for 6 hours of sleep. And part of my job working with her was to convince her to shift her bedtime slower, later, use melatonin to help her sleep initiation, and just reduce that her bedtime so that her sleep is more consolidated. And this is what sleep restriction therapy does. It's trying to make sure that, we make sure that the bedtime is commensurate for the sleep time that we are aiming for. So that, oftentimes there's this theory, if for example, somebody can sleep, target has a sleep of 7 to 8 hours, but if they're spending 12 hours in bed, then oftentimes that sleep gets spread out over that 12-hour period and it becomes fragmented. And if we can just consolidate sleep in a shorter bedtime, that will, it actually helps a lot of their insomnia symptoms. And so this sleep restriction therapy goes through step by step of how, we can adjust their bedtime, adjust their sleep duration, keeping sleep diary, and how we can do that over multiple visits to come up with a plan for their, for their insomnia. Yes, you can see how about the pharmacological approach to insomnia? And I must say, disappointingly, I wish there was a pill that you could take that could cure most patients of insomnia, but the reality is that there is very weak recommendations and very generally low quality evidence for any of these pharmacological approaches for insomnia. Probably the two most commonly used are melatonin and suvorexin. And I wouldn't, and also for for some patients who are on chronic benzodiazepines for insomnia, if they have OSA, they often worsen OSA. And of course, they also have the potential to be addictive. So when we are thinking about, Sam has already summarizes the treatment for obstructive sleep apnea. And so when we have the approach for a patient who has both of these conditions, I think what we should do is consider what we have available in our arsenal for treatment. And for OSA, as Sam has already described, continuous positive airway pressure, management Emerson spleen therapy, position therapy, surgery, weight reduction. And insomnia, we have cognitive behavioral therapy for insomnia, stimulus control therapy, sleep restriction therapy, bright light therapy, especially for the morning, and also pharmacotherapy. We should consider all this approach, and then we could to try and pick one or two in each category to best to achieve some of the sleep goals that we may share with our patients. We also should treat comorbidities where if they're pain or reflux or mental health, we should treat other comorbid sleep disorders like restless leg syndrome or delayed sleep phase. Consider impacts of their medications as well, and alcohol and caffeine on their sleep. So I thought I'll quickly go through a few case studies, and we will talk about some approaches that we could take. So this is another case. So the first case we talk about mainly cognitive behavioral therapy, insomnia and CPAP. In this case, it's slightly different. This is a very young 35-year-old gentleman. He usually watches TV until 2 a.m. Will often take 1 to 3 hours for sleep initiation. He gets out of bed at 9 a.m. Background of depression, anxiety here. And this is, we thought, okay, this guy might have a slightly delayed sleep phase. And on top of that, given that he has some risk factors for OSA, we talk about, and he has some insomnia symptoms as well. And given that he's a background of some risk factors for OSA, we also did a sleep study. And this is what his sleep study showed. And you can find that, interestingly enough, he has mild sleep apnea with an AHI of 9.7. So you can see that, and interesting enough for him, when he is in supine sleep, he tends to get more, desaturation and sleep disturbance. And you can see the up and down motion of the oxygen saturation. And so his supine AHI was actually 9.7 per hour compared to his non-supine AHI of 3.9 per hour. So actually his non-supine AHI was within normal limits. And given that he had already such a propensity for sleep disturbance, we did discuss a trial CPAP, but we decided to use positional therapy instead for control of his sleep apnea, because the non-supine AHI was actually normal. In addition to OSA, he clearly has a degree of insomnia and his difficulty with his sleep initiation, but also he has this propensity for a delayed sleep phase syndrome where he tends to go to bed late and wake up late. And sometimes when he has difficulties falling asleep in the first place, he will get he'll get sleep deprivation. And because he has to wake up for bed, he wake up for work at 9 a.m., you'll find that if he's watching TV till 2, sleeping, and then taking 3 hours for sleep, he might only sleep for 4 hours before he has to wake up at 9. And so there's a degree of sleep deprivation because of his difficulty falling asleep, and then also his tendency to stay up late. So in this case, we actually discussed some treatment goals of what is a reasonable sleep time. And I think in the end we agreed for 12 a.m. to 8 to 9 a.m. as a general rule for him. And we did with the help of actually melatonin to shift his cycle a little bit forward. And we also used positional therapy as a treatment. And I think Sam has described to you already what you could do, and position like a night shift sleep positioner, something that you wear around your neck or around your chest. Every time you lie on your back, it buzzes you to change position. And what I like about this positional therapy is that you can actually monitor. Whether it's as efficacy. And so you could monitor things like sleep efficiency. You can monitor things like the time that you actually spend in supine sleep. It often gives you a readout as well, how much time it took the device to shift the position of patient to a non-supine position when they have, as soon as they lie on the back. They also measure things like snoring, and so we can figure out as well like how much snoring they're having, above 50 decibels while they're on this device. So it's a very useful adjunct, because probably, especially in patients with, mild sleep apnea, who may not be as tired, who has insomnia, I'm really trying to use a treatment that is not as intrusive, perhaps as CPAP, or who might cause more sleep disturbance like CPAP. So just to summarize that, when we are thinking of treatment of, sleep apnea and insomnia, it's very important to look at the availability of all the treatment options, and because the three comorbidities, and because the constant impact of medications and alcohol and caffeine intake. If there's one take-home measure, if there's one take-home message, or two take-home messages that I could leave, is that I think if patients have difficulty acclimatizing to CPAP in OSA, I think we really need to consider whether the patient has also a concurrent diagnosis with insomnia. Sometimes it's because sometimes CPAP intolerance can be due to just a different endotype of OSA that the patient's having. But oftentimes, we really need to figure out whether there's concurrent insomnia. And I think when insomnia and OSA coexist, it's very important to treat both conditions. And I think the treatment needs to be personalized, and we've got to treat the comorbidities. Well, that ends the talk from my end. And I think this is the more exciting part is actually answering questions. And so without further ado, I might just end my talk for today.
Thank you, Daniel, for an excellent presentation. I'm going to open the floor to questions now. So to all of the participants joining tonight, if you could please post your questions down in the Q&A box, and we'll give Daniel and Sam a chance to answer away. While we wait for people to type away, I have a question for either of you. I'm just wondering how your management strategies might change if you had a patient who was pregnant.
It's urgency is the main thing, I think, with the pregnancy, because there's even a very small window to do an assessment and plan a treatment before they start to run into complications, which I think are mainly like sort of third trimester and then around delivery, and exacerbating eclampsia, hypertension, and that. My understanding is that essentially we go for CPAP therapy for that pretty quickly. None of the other sort of therapies we've discussed, like those adjunctive therapies, are going to be enough, particularly if it's moderate or severe sleep apnea in that setting. And again, for some of the reasons I mentioned, it's a very quick thing to implement once you have the diagnostic information that the problem you're dealing with is obstructive sleep apnea. Whereas, mandibular devices need to be fitted and they need to be moved and trialed, and then ideally you need to have the study to prove that they work, and the positional devices, apart from very specific supine only, won't correct the whole problem. Daniel might have something to add to that.
No, but I think we have to be clear about what our goals are for the pregnant lady, and there's two aspects to it. One is obviously with fetal well-being and health, and the second is actually mom's actual symptoms. Pregnancy often is a very motivating factor for moms to actually be on therapy, and certainly in setting of OSA. I am looking at the best way to treat that, and often, as Sam, for many practical reasons, it's going to be a trial of CPAP. And I think in that instance, there are that sometimes moms also, a lot of pregnant moms have a tendency to side sleep, especially as as they progress in their pregnancy for anatomical reasons, and sometimes taking into account, the certain positions that might have on the CPAP therapy and the mask fit, and wear full face masks, nasal masks, especially sometimes when they're sleeping on the pillow. So some of those things like you got to take into consideration. But what we generally find is that if they're often very motivated, and if you give them the right support with CPAP acclimatization, they do tend to accept therapy quite well. After finishing pregnancy, I think it's important to have ongoing follow-up and to see whether we can continue to do that. And sometimes we even restage them in after pregnancy, because they often have lost a significant amount of weight. So
yeah, like sometimes it was a problem that was there before that was never addressed, and then sometimes it's a problem that comes on with the pregnancy, with the weight gain, the hormonal changes, and then it can be taken backwards again.
Thank you both for those answers. We've got a follow-up question from Renata in the Q&A. She says, will a pregnant woman be seen quickly in the hospital?
Dan, that's a question for you, I think.
yeah, look,
I'd like to say yes, though.
I would say it has already certainly we triage them as the highest category. And look, in my experience, we get a lot of referrals, especially from the especially from the high risk pregnancy clinic, who often do a stop bang, and they refer for a sleep study, and they flag it as urgent with us, and we do one. As always, I think we can always try our best. I think our wait times especially for pregnant women may not be are generally very decent. I'm aware Carol is online, and she might have even more updated stats than my gut feel. But certainly I can say that we really do try our best to see pregnant patients who have sleep apnea as timely as we can.
Thank you. We've got one more question in the chat for tonight, and that's what are your thoughts on using medicinal cannabis for sleep and anxiety coexisting with OSA or CPAP use?
Wow, that's a hard one. That is a very difficult question. Again, again, number one, I don't prescribe medicinal cannabis, so I don't have the rights to prescribe that. I've seen it used predominantly in palliative settings that I've been to with tremendous sleep disturbance, and I think that certainly in those instances, that patients have found it quite useful for patients who have difficulties with sleep. In addition to all the other symptoms like pain and nausea in the palliative circumstance. So I've seen like really good results, at least anecdotally, from that. In a non-palliative setting, and I think I'm not. There's always a case report here and there, or case series with someone who has done some form of study or done some form of done some some sort of study, small volume study that showed maybe some benefit, but I don't think the evidence is very strong. And if you look at the pharmacological approaches for insomnia, generally pharmacological treatment has very little evidence. So I can't really support necessarily medicinal cannabis as a general rule for sleep for insomnia. Having said that, there are some patients who have already gotten from a practical perspective, there are a lot of patients who there are some patients that come to me that been on this medicinal cannabis that was prescribed by a different practitioner for many years, of which although there is no strong evidence to support it, has somewhat managed to control the symptoms. I may have a discussion with patient, but may not necessarily stop them. There's all a discussion about their treatment goals, what's our sleep target, whether there's concurrent sleep apnea. We sometimes discuss a trial if they want. And certainly I'm in discussion with one of my patients who is using marijuana in rapes, which I know has a clear demonstration of harm. So not just we're talking about using, cannabis oil like CBD drops, we are talking about patients who's putting marijuana in his e-cigarette to vape. And in that circumstance, I counseled him to stop, and we're looking at alternative therapies, including cognitive behavioral therapy, plus melatonin, plus other things. But for the most part, but because there was clear demonstration of harm especially in marijuana use in e-cigarettes. So short answer is that very poor evidence. From practical perspective, it depends. Marijuana win e-cigarettes, definitely a no for me.
Yeah, and the only thing I was going to add, because I remembered randomly reading it last night, is that it's actually clearly not recommended in the guidelines for use, at least in the setting of sleep apnea, and citing a lot of those issues in addition to, generally speaking, the variability can be variability in delivery and access and regulation obviously is a big factor as well. There's no like standard doses that are well studied.
Thank you both. We have one more question in the chat, and that's, do you see many patients with treated ADHD and sleep disturbance, and how would you approach investigation and treatment options for these patients?
Oh, wow, great question again. So, we actually do see some overlap with that. And you got to remember as well that, patients with ADHD, some of them are on stimulants too. So they are often on stimulants during the day. And so, I've got to figure out firstly, what's the spectrum, what's the ADHD has done, how the diagnosis is made. I've got to figure out whether the stimulants that you use during the day is contributing to insomnia during the night. And the worst thing that sometimes happens is that, there are sometimes that patients come to see me and they want to sleep. So actually, I say, look, let's just try to fix the medication first, because clearly I don't want to be also in a situation where I prescribe more things or do more sleep studies when, the insomnia during the day is causing you to, the stimulants during the day is causing insomnia, of which they're taking some sedatives to sleep at night, which makes them tired during the day, and they take more stimulants and you go through this cycle, right? So oftentimes, the first consultation is just figuring out what the ADHD is doing, figuring out what the sleep is doing, figuring out whether there is concurrent, sometimes they have concurrent, OSA, sometimes they have other things like restless legs or insomnia, and just figuring out what the sleep problem is. So it really depends. How I approach this investigation is first a review of the ADHD, review of the medications, considering the sleep problems and what the potential list of diagnosis is. Often, I might sometimes adjust the medications a little bit in conjunction with GP and then do a sleep study. I have had a patient who actually had both ADHD and obstructive sleep apnea. And actually, even though her AHI wasn't very high, she was really sleepy. And interesting enough, with treatment of the OSA, she actually felt significantly better during the day. And actually could, I think, and that could lead to like further adjustment of her ADHD medications. So, the short answer is it really depends. And we just got to figure out what is contributing to her sleep disturbance at night and what potential other sleep diagnoses we may have, and then take it from there.
Thank you so much for those answers. We'll just give everybody one more moment. If you have any last questions, please ask away in the chat box. Now is your time. Okay, if we don't have any other questions that have come up in the chat, we might wind up for the evening. A very big thank you again for everybody for coming tonight, and a big thank you to Daniel and Samuel for excellent presentations this evening. The next sleep webinar in this series is scheduled for May. The date's to be confirmed, but will go up on the CHN events webpage. We've got Dr. Ansari and Dr. Jones presenting on restless leg syndrome and circadian rhythm sleep disorders. The evaluation surveys for tonight's webinar will be sent out shortly, so please fill in the post-event evaluation survey so that CHN can email you out a certificate of attendance after tonight's event. And please remember to self-report 1.5 hours of educational activities for your CPD home. Resources, presentation slides, and YouTube recordings will all be emailed out to participants who complete their evaluations. So please look out in your emails and remember to fill those ones out. Big thank you to everyone and good night.